Welcome back to another episode of Care Transitions Today, a healthcare podcast that focuses on case management and transitions of care. This podcast is presented by the American Case Management Association, and it's underwritten by the Pfizer Foundation. I'm Deb McElroy, I'm your host, and today is our 8th episode in our COVID series, and we're going to be talking about the physician perspective on COVID-19. And I am delighted to welcome our guest today, Dr. Ariana Peters. Dr. Peters is a hospitalist with Mayo Clinic in Arizona since 2011. She is the care management medical director there and the lead physician advisor for their clinical documentation improvement efforts at that campus. She is also a founding member of the Association of Physician Leaders in Care Management, which is associated with ACMA. And so we've worked together and just delighted to have her here today. Ariana, I'm going to kick it to you and just a little bit about your background. And then I think this is so important, so we'll dive into just getting some of your thoughts on what's happening in today's environment.
Absolutely. Thank you so much for having me as part of one of your podcasts. I find it to be just an amazing experience to be included in something like this. And it's very humbling for me specifically, not only to participate in something like this, but also to be part of APLCM, to be part of the ACMA. I'm a proud member of ACMA and a huge supporter of everything that they do. And I have found that I've learned so much information from not only being on APLCM, but from attending ACMA conferences and being part of those meetings. They're wonderful learning opportunities. And I know that I have grown personally as a physician and as a physician advisor in the things that I've learned from being part of the ACMA and part of APLCM. It's been a great experience. And I feel very lucky that I've been able to experience all of that. So it's wonderful. In terms of my more personal perspective, I joined Mayo Clinic Hospital here in Arizona in 2011, as Deb mentioned, and I've been a hospitalist here since that time. I was lucky enough to become the care management medical director about a year ago in November of last year. And then earlier this year, I also took on the additional role, as Deb mentioned, of being the head physician advisor for clinical documentation integrity. So I've been busy over the past several months adjusting to these new roles. And in the middle of all of this, COVID hit, and we had a lot of initiatives here in our department within care management to try to improve our discharge barriers and to try to mitigate just the overflowing of patients that we have. We're a very busy hospital. We have a lot of beds that are full. And then we landed ourselves in the middle of a pandemic in the middle of all of this. And so it's been an interesting year. I've grown a lot in the past year. I've learned a ton in the past year. And I feel very fortunate that I have a wonderful partner in the administrator for our care management department here. Without her, I certainly wouldn't be able to do what I've been able to accomplish with this department. And so I value her input very, very much. And I will give a shout out to her, Kathy Zering. She's amazing. Hopefully she will be able to listen to this podcast and be proud that I'm mentioning her. So she's a member of the ACMA as well.
That's great. Thanks, Ariana. I'm going to dive in because actually that's a great segue to the folks that I believe benefit from listening to the podcast, and that's the case management professionals, whether they're physicians, nurses, social workers, and it particularly in your role as a physician advisor. I know the pandemic shaped and changed a lot of what we do operationally on a day-to-day basis in order to be really responsive. So can you just reflect on how your role, again, you said you've been in it for a year, so new to that position, but how has it changed? What did the pandemic do to sort of change that role of physician advisor? And then also how you think about the clinical documentation improvement or CDI efforts that you've been involved in?
Absolutely. Well, so we have expanded our physician advisor program here at Mayo, Arizona, to include 4 physician advisors at this point, myself included. I think the thing that's special about our program is that all 4 of our physician advisors are hospitalists, including myself. And so we are experts, if you will, on managing hospitalized patients. And so the choice of that was deliberate because we know that hospitalists tend to know the inner workings of the hospital, I think, better than anyone else in terms of being able to move patients in and out of the hospital and knowing about discharge barriers and things along those lines. So having all 4 of us be hospitalists and having all 4 of us taking care of COVID patients when we are working clinically, I think has been a benefit that we've been able to bring our clinical experience into the work that the physician advisors are doing. In addition to that, our physician advisors are much more heavily involved with our interdisciplinary rounds, and that was one of our big projects that we were starting to work on right around the time that I assumed the role of medical director. And then when COVID really hit us, we didn't really see the surge as early as we had anticipated that we would. It seemed like it kind of hit on the coasts first, and then it sort of migrated inwards. And so we didn't really see the spike until later than we anticipated it, but nevertheless, we were kind of preparing for it. And as I mentioned, our hospital we were already overflowing from, just being at capacity prior to COVID hitting. So we were already starting discharge initiatives and working on interdisciplinary rounds and all of these other projects that we were working on to mitigate discharge barriers. And then we had a pandemic on top of that. So the physician advisors have become even more involved in terms of reaching out to providers if necessary, being more present. The fact that we are present at all in the hospital and we have to be here all day long, we are present, we are available, we are there to discuss any discharge barriers with any of the providing services. We help with all of that. And we're also present for interdisciplinary rounds as well on as many floors as we can possibly be to, again, help discuss those longer lengths of stay, those discharge barriers. How can we help mitigate those? We're much more engaged, much more involved, and we definitely are taking a bigger part in not just the presence of the discharge barriers and that part of things, but also in clinical documentation too. We've seen an uptick in the number of queries that are being sent because we're seeing a higher number of patients, and our, the number of queries that are being sent to our providers, in particular to my partners in hospital internal medicine, has practically doubled in the past year. So we also have to help with that because that's also part of explaining why the patient is still in the hospital, looking at their observed to their expected mortality rates. All of those things factor into those patients still being in the hospital and why they're so sick and why they still need to be in the hospital. So our physician advisors are helping with that too. So we've seen our role morph into doing so much more than simply over the past year. And oh, by the way, we had a pandemic on top of that. And so our physician advisors have been reaching out to primary services, talking about outliers with longer lengths of stay. We've had all of these initiatives that we're working on that the physician advisors are much more actively involved with than they previously were about a year ago.
So a follow-up question to what you're describing is you're talking about your team who are all hospitalists and in the hospital. How did post-acute, like your referrals to the post-acute network, how was that impacted, and did you see any change in the way you operated? In our previous episodes, I know a few people have talked about how critical that was.
Yes, I think one of the major programs that we've implemented has been our remote care at home program. So especially for the COVID patients, we don't have the bandwidth yet to include non-COVID patients yet. We are looking into that. But right now, especially as there's this next wave and next surge happening, we had to back it back off again to simply being COVID patients. But we're looking into the high utilizers and, potentially like the sicker heart failure patients, the ones that might have devices, things like that, to add to the remote care at home program. For right now, however, it's mostly limited to the COVID patients. And so when we discharge those patients, they're being sent home with this remote monitoring equipment that we're helping to monitor them at home. And I think that part of that has helped with hopefully reducing readmissions as a result of COVID specifically. And actually, it has contributed to bringing some patients back into the hospital. Those patients that did go home, sent home with this remote monitoring program, and then for whatever reason, their saturations continue to be low or they're not doing well at home, then we've brought them back. And I think it's brought a sense of security to those patients that are being discharged with that equipment, because the patients feel safer. They're scared. Their patients and their families are scared because of this, and rightfully so. And I think it gives them some sense of security that someone's watching them, someone's keeping an eye on them, even though they're going home. And so I think that has helped with getting patients out of the hospital. It's something that we've used as a part of the discharge process to get those patients, home that may not necessarily feel comfortable going home otherwise. So I think that that's been a great help. I think we have seen a significant increase in our telehealth work as well. I think that's been seen across the country. We're seeing more and more of that. And also, I think the constant watching of elective surgeries and procedures, and looking at that on a daily to a weekly to a monthly basis to see if we need to mitigate those numbers and look at those procedures that were planned. Do they really need to happen? Can they be postponed based on our census? Do we have the capacity to be able to manage those patients? Do we not? So it's been, I think it's almost like an accordion. We've had to flex and expand and contract back down with the surge in the census, with the surge in COVID numbers, with these ups and downs that we've all been experiencing. We've had to incorporate more flexibility than ever before in so many ways, and just come up with more creative ways to do what we were doing before and do it safely and still take good care of our patients and their families, while at the same time mitigating the fact that we now have, at least in hospital internal medicine right now, half of our census approximately is COVID patients right now.
Wow. So the significant population.
It is.
I think people will be curious. Do you consider that part of a second surge, or have you had that sort of heightened, although your probably ramp up of the COVID patients was delayed, it sounds like, from the two coasts. Has it been sustained over time? Are you seeing sort of a peak and then reset and then another surge?
That's pretty much what we're seeing. I'm not an epidemiologist by any stretch of the imagination, and don't know the exact numbers and science behind things and all of that. I wouldn't want to speak to that. But I see the numbers. I see the graphs every day. I look at them because I'm one of the hospital mid-level administrators. And so I have the access to that. And yes, I would say that this is a second surge. There's no doubt about that.
Okay, good. I think people are interested in that. Again, I'm going to just continue the discussion about that role as a physician advisor, and again, in your role as a hospitalist. Can you talk about your emergency preparedness planning and some of the efforts that went on in the midst of the last months with the pandemic?
Absolutely. So we in hospital internal medicine, we have a plan, again, kind of like the accordion that I referenced. So based on our census, rather than having our physicians and we have a significant number of advanced practitioners also in our group. I think there's a total of about 60 of us, 60. So there's quite a few of us in our group. And so we also are a teaching hospital, so we have to be able to take care of our residents as well. So all of those people are working at any given point in time. And so the way that we have chosen to do this is it's been census driven. So if our census surges to a certain number, we pull in another doctor, and we try to have one-to-one staffing with our advanced practitioners, so that we have basically a team, so that there's a certain number of teams that are present during the course of the day that are rounding at any given point in time. And we have flexed up from starting at 5 rounders and a corresponding APP to 6 to 7 to 8 over the past few weeks. So right now we have 8 rounders that are currently working even as we speak. And as the physician advisors, even though there's only 4 of us, again, we are part of the hospital internal medicine team. So we are back up for number 9. So It's possible that we may be pulled in to help round if our census goes to a certain number. So that's been our response. We've had to be creative, and there really was no other choice to pull in the physician advisors, even though our work is absolutely necessary and critical to what's happening, especially in terms of care management and discharge barrier mitigation and all of that. However, we are part of the HIM team, and therefore, if it's needed to bring us in, that's what we have to do. It's just a matter of if you have the people around, because we're here in-house, we're here in the building, we're available. So if it's getting to be that busy, then we have to come in. So we've made that agreement that that's what we will have to do. If it gets even higher than that, then the next part would be to pull in either the backup people that are on for backup call for sick leaves and calls and things like that. And beyond that, we actually may even have to tap into our outpatient providers if it gets to be so busy that we need additional providers to do so. So there we have a whole plan in place. And it's all census driven basically, as to when we hit a certain number, we pull in another provider. So again, it's like an accordion. We flex up and down depending on the census. So if next week the census drops back down again a little bit by a certain number, we will drop back down by a provider. So we've had the ability, thank goodness we have enough staffing now. We didn't about a year or two ago, but we do now because we've hired on additional providers. And so we have enough staffing now to be able to do that. So that part has been better for us because we do have a little more flexibility than we had previously. And so it's made it a little bit better in terms of just having the extra people around to come in and help when necessary.
That's great. And is there anything, I think that flexing is something out of all of the episodes we've had associated with this podcast series, certainly we've heard over and over again. And I think it was sort of the underpinnings of how to be resilient in this environment. So as you think about that, can you think about what you weren't prepared for? Is there anything you weren't prepared for at the beginning of this? Was it that kind of thing where you had to have a different staffing model or provider, look at the provider ratios different? What was new or what was a learning?
I think the learning experiences were exactly that, is that we knew that we were going to have to staff up. I don't think we realized we were going to have to staff up to the degree that we have. However, we learned as we went that we were going to have the backup for the backup for the backup. So we have been able to do that. So I think that was one thing that we learned. I think, frankly, we do know how to take care of these patients better now than we did before. We have a little bit of a better sense in terms of how these patients tend to react clinically. We can tend to see which ones we think are going to decompensate faster rather than others. We do have a little better of a clinical sense how they're going to do, not always, but I think we do have a better idea of how to take care of these patients. I think the fear part of it is understandable, still there. I think, but now that you almost get used to the new normal, if you will, this is our new normal now for right now. And I think several months ago, it was such a novel thing that there was an even more significant amount of fear associated with it. Not that there isn't now, because I think it's a different type of fear. It's the fear of how are we going to keep doing this? I think people are getting COVID fatigued. And so I think that that's something that is affecting us long term. I don't think that we anticipated how long this would go on. And the fact that there doesn't right now yet appear to be an end. Hopefully with the vaccines coming, this will be the end or the slowing down, if you will. But I think that's the other thing that people didn't anticipate is how long this would stretch out. It's been a marathon, not a sprint. So. Yeah,
absolutely. And I guess that was one of the questions I had for our discussion today was going back to the title of this podcast. It's like the physician perspective. So when you talk to your colleagues, when you reflect, and I think that fatigue certainly is a theme. Anything else that you've seen as a direct impact to physician practice, as you're going forward? I know we've had discussions about reimbursement and, that flexibility you talked about, but anything else, or just that personal impact?
I think a lot of it is the personal impact. I really do. It's hard to take care of these patients. It's physically hard on your body to have to wear the protective equipment for as long as you have to throughout the course of the day, even though you get to take the mask, well, some of the masks. Some things you get to remove, some things you have to keep on. But it's very difficult to wear all of that for, a 12-hour shift. It's hard. It's physically, you're hot, you're tired. You can't even take a drink because you can't take your mask off to take a drink of water. So it's very hard on your body. And then the emotional toll that is being taken on all of us. I mean, we're watching all of these patients and their families. They can't have their loved ones come see them in the hospital. Our hospital currently right now has a no visitor policy. And so, these patients are by themselves. They're scared and they're fearful, and it's very difficult. And a lot of these patients that we've had long term, there was one patient I can probably mention because her story was on Good Morning America, so I don't think I need to, conceal too much about it. But she was on ECMO for 88 days. And so there was a lot of emotional attachment, in particular in the intensive care unit for their staff, because they became very attached to this patient, and she did discharge out of the hospital, and we had a celebration in the lobby for her because she deserved it. Their family went through a lot, and so to see some of these success stories is bolstering, I think, for the staff, because they become so attached to these patients because they're here for so long, especially the really sick ones that end up in the ICU. The staff can become very attached to those patients, and so, and justifiably so, because we want to help them, we want to make them better, and they're so sick. So many of them are so sick, and they struggle for so long. So to see them come out of the hospital and make it out and get out of the hospital safely and in a better state is just wonderful for all of us to see. So I think encouraging those celebrations when they can happen, I think, is very important for the mental health, not only of the patients and their families, but for the staff.
Well, and I was going to ask you about the staff. You talked at the beginning about your partner, Kathy Ziering, and how you're, part of the leadership team for care management. When you looked at your case management staff and certainly you're addressing all of the staff, but anything in particular that the two of you worked on, or any strategy that you thought, okay, this is where we're at and we're going to be consistent in how we move forward?
I think from my perspective, what I can do being on the physician side is that I would like the staff to know within the Department of Care Management, not just Kathy as my administrative partner, but the whole department. I would like them to know that as the medical director, I am present for them. I want them to know that I am an advocate for them to hospital leadership, because I am the link between their department and hospital leadership. As the medical director, I think that that's one of the things that I can help with. And so I make an effort to lean in, if you will, and be there for them, be present at their staff meetings, tell them that hospital leadership is listening, because I know they are, to make sure that they're aware that leadership of this hospital understands and knows that they are being just as stretched as, the physicians and the APPs and the nursing staff and everybody else. I think that's been one of the biggest changes in the past year since I assumed this role, is we have really connected with our hospital leadership to make sure that they are aware how valuable the care management department is in any hospital, and the things that the care management team does and what they are able to do for patients and their families, not only before the patients come in the hospital, but during their hospital stay, obviously, and then post-hospitalization as well. That transition, that movement through the hospital system could not happen without an amazing care management department. And I have to say that we are very lucky here because we have an amazing team here. We really do. Not that there aren't other amazing teams across the hospital or across the country, because I'm sure there are. But we really have an amazing, solid team here, and I'm very lucky to be able to work with each and every one of them. And so I try my best personally as the medical director to be that link between those individuals and hospital leadership so that hospital leadership is aware of everything that care management can do. And not just the case managers, the social workers, the care management assistants, the chaplains, all these people that are part of this team that help these patients from every other aspect of their care and how important that is. And especially with something like COVID, where you have patients and families that are so fearful. There's so many more social determinants of health that need to be addressed and looked at as part of this disease that weren't even necessarily considered, or maybe not necessarily not considered, but didn't seem to be as important, but now they are. I mean, we have so many patients that have lost so many family members or friends to COVID. In fact, one patient that was just discharged today, that's kind of a similar situation. So that's going to impact those patients and how they get better. If they have a difficult situation at home where the patient's husband has COVID and their son has COVID, and what if the son is the caregiver for both of the parents, and how do we handle that? Those are all challenges that care management has not had to face to such a degree, I don't think, that the pandemic brought out. And it has really brought care management, in my opinion, to the forefront of our hospital, here at least, to really show how important the care management department is.
So when you think about going forward, as you're reflecting on the social determinants, whether it's food safety or housing or caregiving, whatever those key issues are for the people who have been hospitalized or going home. Again, I think there's an acuity to the situation where what existed is magnified. So going forward, as you reflect on what you're doing at Mayo, is there any best practice? Is there anything that changed that said, this is ramping up so much, we have to help case management do X? Is there any best practices or practice changes that you saw from the medical side or from the case management side?
I think, honestly, we just needed the staff. And so I think that we've been able to bring that to the forefront as a result of that. I think our hospital constraints in terms of bed availability, we're already starting to bring that to the forefront. And then this was on top of that. So we were already full before this. And so now we're just more fuller. So we have to find a way. And part of that, frankly, is to have the staff. And so I think, again, as part of my role as the medical director, I can be vocal to hospital leadership about that and to raise the awareness that needs to, and the spotlight that needs to be shown on care management, to show what the care management team can do. And if you have the staff to be able to do that, then look how much more can get accomplished. And so I see that as part of my personal responsibility to be the advocate and be the bridge in between the nursing administrators of care management and hospital leadership.
Do you have any comments or thoughts on the waivers that were put in place for CMS to, really address some of the capacity issues? Thoughts on that and where you think that's headed?
They have been very helpful. I can tell you that there were some patients that needed placement that might not necessarily have gotten placement because of their admission status. I think that we will continue to need those waivers. Thank goodness they are still in existence because we have been utilizing them. And especially when you need the beds and you need to open up spaces for new patients, it definitely helps to have those waivers in place. Frankly, I hope that CMS and any other government representatives or whoever it is that makes these decisions will learn and listen from these experiences and realize that some of these changes that should have taken place a long time ago, like including observation nights in terms of the amount of time that will go towards approval for getting skilled nursing facility placement, including observation time in that time as opposed to 3 midnights as an inpatient. Making those changes, hopefully things will change in terms of what is going to be allowed going forward, and adjustment of these rules accordingly, because I think, and I know that's something that the ACMA has been advocating for quite some time, is to include the observation time in the total time as opposed to making it strictly as an inpatient. And I am a strong advocate for that. I think that it would help us in moving our patients out of the hospital faster. And so hopefully the powers that be that make these decisions will look at what were the benefits of these waivers when they were in place, and what can we take from those benefits as the best parts of those and implement them going forward.
Oh, good. So in your, a continuation on that theme, in your role as physician advisor and some of the things you normally would see as part of utilization management, any other comments or observations about just the commercial payers or any of those other folks, any trends that you're seeing?
I think one thing that we've seen is just that we've learned to treat COVID as we would, in some ways, any other viral illness. And by that, I mean, if the patient is on oxygen or not, if the patient is on IV steroids or not, if the patient is on, say, IV remdesivir or some other IV treatment that, is being administered. Those are criteria for any illness, not just specifically for COVID. So I think that as long as we follow those requirements for meeting inpatient criteria, we have not seen a lot of denials as a result simply because of COVID. We are watching that very closely. One of the things that we do here in our management is we look at and review every single observation case in the entire hospital. We look at every single one, every single day. And so we very closely monitor those cases to see if they will meet inpatient criteria and get them converted if they meet. So we're not treating, in other words, just because a patient has COVID doesn't necessarily make them meet inpatient criteria, if you will, and in particular with regard to commercial insurances. So we do watch that very closely. And I don't think that we have seen a big increase in denials or anything like that because we've implemented that policy. So I think we're on the right track, I think, with that.
It sounds good. So I would just ask, as you're reflecting personally on how you're going to maybe think about your practice going forward, anything that changes. We're trying to imagine a post-COVID world where it maybe doesn't disappear, but certainly isn't what we're seeing today.
I think for us specifically, we were having so many bed availability issues that it almost, in the middle of these two waves, if you will, we almost went back to our old normal, which was we were at capacity because we were just at capacity. So we had to revisit and revamp all of those projects that sort of took a back seat when we had our first wave of these patients and when we first started dealing with COVID patients. We had to revisit a lot of those projects that were kind of put on the back burner for a little while. And then now we're seeing the second wave of patients. And so again, those things that we were working on, again, had to go back to the back burner again while we continue to focus on these COVID patients. So I anticipate that hopefully, if the vaccines that are coming out will work and that people will take them, and that we get through the holidays and people are safe and responsible, and hopefully that is the case across the country, that we will probably go back to that normal, if you will, in quotation marks, and we're going to have to revamp and revisit some of those projects again, and we'll go back to that eventually, and we will continue to work on everything that we were working on to improve our discharge efforts and work on our readmissions and all of the things that we were doing that kind of had to take a pause. But yet I think we will take some of the things that we learned from this going forward. For instance, we're doing so many more things over telehealth now than we ever were. The remote monitoring program that we have here specifically, I think we will take these lessons and utilize them as we move forward to what our new normal after COVID, if there is an after COVID, and hopefully use those things that we have learned and some of those projects that we implemented during this whole year and take the best of them and really use them to go forward. So I'm hopeful that that's what takes place. I know that that's something that we will continue to look at going forward. We're looking at expanding our remote patient monitoring program. We're looking at expanding our telehealth programs here. We're not a big hospital, so for us to have, we're not the size of Rochester here, so we don't have as many resources as they do, but we're growing. And so we're going to have to expand in a lot of ways. And so if we can use some of these programs that we've had to come up with as a means of learning and better care of our patients and make things more efficient and work in a smarter, more efficient way, then I think we should continue to do that.
And physician perspective, again, or provider perspective, because you do have like a large contingent of APPs. There's enthusiasm, do you think, for some of this innovation that has had to come forward, the remote monitoring, the telehealth? Are you seeing a lot of enthusiasm for looking forward for that?
We are. And we have, if I can toot the horn of our internal medicine APPs just a little bit. I don't know if any of them will even hear this podcast. Hopefully some of them will. They're amazing. We have an amazing group of APPs. They're just so hardworking. They do so much amazing work for us. We couldn't function without them. And so I think the utilization of APPs in general, I think, is something that should be expanded and utilized. If they're able to be used to continue to keep people healthy and try to mitigate this bed crisis that we have across our whole country right now, then I think we should. We should use whatever we can, however we can, to keep our patients safe and to care for them effectively and still use our resources as best as we possibly can.
So physician assistants and nurse practitioners are all standing up and thanking you. I can hear a standing ovation. Well, I so appreciate you being with us today as we're winding up. Any last thoughts that you would want to share with, the case management professionals, your physician colleagues, and really folks that are not any of those, but who might be tuning in?
I just would like to say again, I'm so blessed to be in the position that I am in. I am very lucky to work with such an amazing group of such hardworking and professional individuals. I remember telling Kathy specifically a year ago when I took this position of medical director over care management that I was not going to be the same person a year from now that I was then. A year has passed, just about, and I can tell you that I am not the same person now that I was then. I have learned so much in the past year. I would say predominantly about communication. And so I think that is something that I will continue to take forward, is learning how to communicate and to get my message across with including being inclusive of others and really being part of a collaborative team. Our team here is just amazing. I can't say enough good things about them. They are such hardworking people. They're good people. And I personally feel very blessed to work with them on a day-to-day basis. And I have learned so much, frankly, from being a member of ACMA, being a part of APLCM, and understanding what care management is all about and the amazing things that care management does for patients and their families. Hospitals couldn't function without a well-established care management team. A hospital could not do what they do. They need them. It's as simple as that. From a physician perspective, I just hope that all of our colleagues know how much I appreciate how hard they work, not just here at Mayo, not just within all of Mayo Clinic enterprise, but across this entire country and this entire world. Our physicians, our APPs, our nurses, even as far as saying, the environmental staff and everybody that works in the hospital, they're all necessary. They're all amazing. They are all valued, and everything that they do is important. And I hope that message continues to be spread not only across the country, but across this entire world. These people are important people, and they do very hard and good work. And so I think that they deserve every accolade and then some that they can get.
Thank you. Thank you. Well said. Dr. Ariana Peters, thank you for joining us today. And I just, as we wrap up, I just want to comment how truly appreciative we are of your time. You were answering pages right as we were hopping on this podcast. Thank you for that, because we know how valuable your time is. To all of you that are listening, we hope you've enjoyed the podcast, and we just ask you to give us a rating and a written review and let us know how we're doing and what we can do better. There have been 8 episodes in season 1 of Care Transitions Today. So today was the 8th episode. If you haven't listened to all 8, we encourage you to go back and do that. Listen to our featured guests. We explored different perspectives and innovative leadership during this really difficult time of the COVID-19 pandemic. Those days continue, but we're really looking forward to a brighter future ahead with the vaccine. We want to give a huge thank you and shout out to our underwriter, the Pfizer Foundation, for making this podcast season possible. There is more to come. There's going to be a season 2. So please don't forget to subscribe to the podcast so you're notified right when that comes out. And until next time, thank you so much for listening.